You are most welcome to this talk, and a warm welcome back to Professor Angus Dalgleish. Professor, thank you so much for coming back.
You're welcome. Delighted.
Now, for the last 24 hours or so, I've been trying to unpick your rather excellent paper, written with... can you pronounce his name correctly? Y.M. Lai?
Wei Lu, we call him.
Wei Lu, okay, yeah. Who's more the lab scientist and you're the clinician. Naltrexone at low doses and its relevance to cancer therapy. So if we start with the naltrexone story, I mean, basically, this is one of those repurposed drug therapies which seems to be immensely efficacious, that is simply not being used because the clinical trials aren't really there at a large scale. The clinical trials aren't there at a large scale because no one's paid for them. Big Pharma's not picking it up because there's no money in it. And it seems to me that this is one of those complete scandals. I mean, we've talked about your Mycobacterium vaccae IMM 101 preparation before, and we'll maybe mention that later on. There's something deep inside me that's outraged by these obvious things that people like you have identified, and yet simply aren't being done. So I've traced the naltrexone story back a bit. In 1963 it was developed for treating opioid addiction, basically, opiate use disorder, I think we would now call it. And that follows on naloxone, which was the first one, which goes back to 1961. But naloxone had to be injected, whereas naltrexone was orally available. So what is the story about naltrexone being used for opiates and the higher dose, and how did you come to realize the potentially huge benefits of the lower dose naltrexone?
Well, thank you for letting me tell you how I discovered it, because it's very important. I didn't discover it from other doctors. I didn't discover it from any textbooks, any journals, anything like this. I discovered it from a patient who I said, "You are doing incredibly well." She had been on a vaccine program which had been curtailed because the company had stopped the vaccine. But we're talking months later, when she had a stage 4 melanoma. I would have expected to have progressed. She was, not only was there no evidence, everything had regressed, and she was doing really well. And I said, tell me everything you're taking. So she said, what you told me, which is actually vitamin D and aspirin, green tea, the things that we thought were very useful supports.
Absolutely.
And I said, well, thank you, but something tells me you're taking something else. And
you just had that clinical intuition.
The next time she came out, she said, "I'm terribly sorry, I should have told you, but I was told it wasn't an anti-cancer thing, and I'm taking low dose naltrexone from a clinic in New York." So I said, what's that? I regard naltrexone as something we use for opiate overdoses, addictions, etc. She says, yes, that is it. And I got it from a Dr. Bihari there. So rather than just dismissing this, I said, where is it published and what can I get hold of it? And she said, well, you must go to the clinic next time you're in New York. So I actually did. And I went there. I had read a lot about this, and I was very suspicious. I mean, you are, aren't you?
It sounds preposterous.
It sounds preposterous.
But great that you had the curiosity to follow that through.
And I was brought up in a pharmacology department in UC under a chap called Professor Lawrence. And, he was the great guiding light. And everything was the more the merrier.
Of course.
You give everything till it starts getting toxic, and you bring it back a bit, and then that's the dose.
Give twice as much; it's bound to do twice the amount of good.
Exactly,
which isn't true, by the way, but that's the philosophy.
So this dose of 200 milligrams, which is the standard, I found that a lot of people who got curious and were using it, they all said it doesn't work if you give more than 4.5 milligrams, not 4, not 5. But 4.5, and they'd independently come across this. So how was it discovered? It was discovered because Dr. Bihari was in charge of the addiction program in New York, and when they've successfully got people off morphine and heroin, this the type of drug, you just reduce the dose and you tail off. And he was surprised at the number of people who asked to go back on the low dose after they'd come off it. Now, a lesser doctor would have suspected this is some kind of trickery to get back on some opiates of some kind.
Yes.
But he was very good. He said, why? And they said, because I've got arthritis or Crohn's or multiple sclerosis. And it definitely improved on the low dose. It wasn't there at the high doses. So he did the obvious thing. He put them back on and objectively monitored and came to the conclusion that this was real. He then contacted a scientist called Zagon, who started to look at it in the laboratory and noticed that the low dose led to changes in the nocturnal release, the circadian rhythm of endocrine and immunological peptides. And it was always thought it was much better to give it at night to enhance this mechanism. And indeed, I mean, that's the way it's been given. And then I was surprised, as usual, to find that there is evidence in the literature that it's effective in Crohn's disease and multiple sclerosis. But as usual, and they're randomised, there's a couple of randomised trials of this, showing benefit, and as usual, the regulatory authorities say, well, these studies are too small, you need much bigger ones. I mean, it's the same old nonsense. I mean, this is a licensed drug. It should have been, what I'm really pushing for is basically that these agents are licensed for post-marketing authentication. So it means I want it so you can write the script, and every month, these things are renewable monthly usually, you just check that everything's okay, and then every 3 months whether there's any objective benefit.
So just to clarify that, Gus, so what was happening is Dr. Bihara was like tapering off the dose.
Yes.
And they found out when it was just at the edge of the taper they were getting these beneficial effects, and he had the astute clinician's mind that said,
yes. Yeah, he
just
really,
a minute.
Yeah, he really, I just thought he was really great, because I know many other people who would have just dismissed this.
Placebo, there were a load of junkies anyway.
Yes.
Yeah.
So anyhow, back to my cancer patient, having seen this, I was faced in my line of work doing oncology with people who run out of every option, but they're not quite ready for palliative care, and they're in this twilight zone. So I started to give low dose naltrexone to these people on the ground. It was sort of informed consent, and they've got nothing else. I'll try it.
So you could basically prescribe that compassionately. So naltrexone was already authorised for opiate and alcohol use disorder.
Yes. So I was using it off label, basically. So I'm allowed to do that. And so
that's compassionate prescribing, isn't it?
And any doctor's allowed to do that. Yeah. But then they get hounded by people, pharmacists, hospital director, whatever it is, their practice, etc., for that it's not properly licensed. But basically, I didn't care, because I was really wanting to help these people. There was nothing else. And then the first sign and evidence that something really good was going on, I gave it to people who got multiple secondaries in the liver from colon cancer, etc., and run out of every option, is they basically said, I've run out, can you give me another prescription? I said, oh, by the way, you think it's helping? Oh, I feel so much better. And this would go on, repeat, and I suddenly find that these people were doing over a year on the low dose naltrexone. I must add, they were also on, the vitamin D and all the other sensible things. But it started to make me think there really is something going on. And then I saw a couple of actual responses, which were quite remarkable. And I thought, wait a minute, you don't get responses like this from altering the circadian rhythm of peptides, and the scientific evidence presented was modulation of opiate receptors, and clearly it matches. But then I became suspicious. Why is there such a big difference between 4.5 and higher? Is it doing something else that the high dose is not doing? So this actually, I must say, this was actually really quite exciting, because I found somebody who was a classical immunologist, who was very, very, very classical, and they had heard me talk about the low dose naltrexone, and they came to see me and said, "I'm very interested in this. How do you think it works?" And I said, "I don't fully understand why. I don't believe it's due to opiate receptor modulation." I said, "Why do you ask? Why are you interested?" And she said, "My mother had lung cancer, and the local doctor there put her on low dose naltrexone, and she did 18 months after they expected her to go. So I honestly think there is something." So I said, "Well, my hunch is there's another receptor involved. It's not the opiate receptor." And I came from a very good background of this, because I discovered the CD4 receptor for HIV, and I did it a totally different way from what anybody else would do it. I basically
this is the receptor on the T helper cell.
I threw a fishing net of every available receptor I could, and devised assays that I could detect activity. So we did exactly the same with the low dose naltrexone, and it was quite amazing. After the first 2 or 3, throwing the fish out, nothing comes back, and it was about the third time we came back, and there was a hit on a thing called TLR9. Now, TLR9 is just an activation receptor on immunological cells, but when it's activated, it produces IL-6, interleukin-6, discovered after interleukin-5. But they also gave a clue as to what it did in the nickname they gave it. They called it the cancer growth factor. So here we had something that was blocking the pathway that produced interleukin-6, cancer growth factor. Yeah. So
right, can I just clarify and make sure I've got this? Because the couple of things I want to just stress: stage 4 melanoma and liver metastases that we talked about. I mean, that is you might as well get the death certificate out. I mean, that is. It doesn't get any more serious than that, does it? In terms of cancer, these are remarkably serious terminal stages of cancer. So the response that you got in those conditions is astounding.
Yeah, obviously not in everybody. Nothing was.
No, but the fact that you saw a response is astounding.
We were seeing benefits you would normally have expected with approved treatments. Put it that way. And with zero side effects, apart from it affects dreams and sleeping a little bit initially, but 95% of people completely disappears there. And then any other side effects, very idiosyncratic depending on what they have. But overall, I'm not worried about side effects with it, except make sure they don't take codeine, because you get some interaction there going on which they don't feel well. Apart from that,
right.
So
this second bit, the TLR. So that, let me see if I've got this right. This is the toll-like receptor.
Yes.
And these are receptors on white blood cells.
Yes, they are on immune cells. A variety, white cells, lymphocytes, and other cells. Basically, it's immunological cells.
Yeah, and normally they will be recognizing a foreign bacteria or virus.
Yes, exactly. They're the first line, part of this innate immune response.
Yeah. And the low dose naltrexone is binding onto this receptor, which would normally identify the presence of a bacteria or virus, this toll-like receptor 9. And that was stimulating the cell to produce this IL-6, and the IL is the interleukin, going between leukocytes, between the white blood cells. Yeah. It's what we would call a cytokine.
Yes.
But my understanding is that this IL-6, this interleukin-6, is the most potent pro-inflammatory cytokine that's going to stimulate ordinary cells to become malignant. Am I roughly on the right? Is that roughly correct?
Well, it certainly if they are already turned malignant, it fuels them.
Oh, right.
Yeah, and that's the way I interpret it.
Right, got it.
And why I think that this is such an important property of this drug. And then, as you know, we found other mechanisms that gave it anti-cancer activity. The most important, I believe, from a practical point of view, is it sensitized all the tumour cells that we have growing in the laboratory. Doesn't matter where they came from, they're sensitized so they die much quicker with chemotherapy. to the point where we could have the cells there, you give chemotherapy, nothing much happens. You get a dose, then they start dying. But if you gave them low dose naltrexone and then the chemotherapy, they start dying very quickly, and you can completely have the same effect with half the dose of chemotherapy. Now, from my point of view as an oncologist, if I could reduce the dose of chemotherapy in all my patients, knowing that it would not reduce the efficacy, it would be unbelievably helpful, because all the side effects are in the top 50%. And it would actually, it gives the confidence, and I've had the confidence to give people start at 75% of the dose, rapidly go to 50% of chemotherapy, and have the same expected response without the side effects. Now, most people with chemotherapy, they're a big burden on the NHS as the side effects. I mean, they're just not horrible. They have to be treated with all these various things, and especially those drugs that hit the marrow. I mean, it's just an incredible amount of care. So here you have a drug that, one, switches off the cancer growth factor, two, sensitizes the cancer to standard treatments, chemotherapy. We've shown it's the same for radiotherapy, etc. So it's really useful. And everyone goes, oh, that's interesting, but it's not been approved. Yes, this is a completely correct argument. But, you know, only you people are actually in the position to do something about it. But who's going to pay for it? Now, it is the attitude now that all trials seem to be only done if Big Pharma's paying for them. So basically, Big Pharma controls the strings. And it doesn't like things like this that are very useful and things, because they would reduce the demand for products down the line. And it's very interesting that the interleukin-6, that, you know, if it is so important, then surely Big Pharma would have targeted. And the answer is yes, they have. If you find to have too much interleukin-6 in your tumour after you've tried all the first lines, then they will sell you a monoclonal antibody to it at tens of thousands. Of course. Whereas my point is, we have something here that will make that unnecessary if you give it in low doses early. The earlier you give this, the better. Remember,
this is what Big Pharma does. It takes away the broad treatments, what you might call the health improving treatments.
Yes.
The treatments that can affect a wide range of potential oncogenic and cancer promoting pathways. And it goes to the far end of just the far end of a bit of minutiae. And it says, well, there's a particular molecule here that interacts with this particular receptor here. Let's block this very specific interleukin-6 activity with a very specific chemical that's patentable for 15 years. Whereas you could do it with low dose naltrexone. It's just so typical of Big Pharma. More and more precise, what I would call clever clogs pharmacology. And it is clever, there's no question about it, going for a really, really specific molecule. Whereas why not just improve the whole thing? It's just drives you mad.
This is really what I've been fighting for, is that if you're going to go, and I've seen it with so many patients, I mean, I'm just an old oncology doctor, I've seen it, they go in, they get offered these horrendous treatments, and they're not well. They're not well. We were very early on. We showed that people who didn't respond early had low vitamin D, and you've got to. It is a waste of time treating cancer patients if they got low vitamin D. Complete waste of time. So that's the first thing. The second thing was realizing that they needed their innate immune system boosted, and that's where the IMM came in, the heat-killed mycobacteria, because everybody with cancer, his innate immune system is suppressed, and you need to rise that up. The importance of the low-dose naltrexone is that cancer is fueled by chronic inflammation, and I've co-authored books and edited books just on that, inflammation and cancer, chronic inflammation and cancer. So here you have a unique anti-inflammatory which is actually damping down cells which produce cancer growth factors. I mean, if you were to design what you wanted, you wouldn't expect it to come up. it's already there. It's just incredible. So with all my patients now, I want them on vitamin D, increase their innate immune response. Won't go into the details of the IMM, etc. on this talk. But you want to damp down that inflammation, and I have been doing that with suggesting they take aspirin, soluble aspirin, and there's a lot of evidence that helps, particularly colorectal and many other things. But I think naltrexone's, even the low dose naltrexone's, even more cancer specific with damping down basically the fuel. You're basically with this shutting off the fuel the cancer needs to grow. So to me, doing those three things first, then you decide what specific treatment do they need. Oh, they got melanoma, they might need these new immunotherapies, the checkpoint inhibitors. And yes, we've already shown, and my colleagues published at ASCO, that with IMM, the 101, if you prime with that, you double your response rate to these drugs without any increase in toxicity.
Everyone with cancer should have the D3 optimized, the D3 levels optimized to 40 or 50.
No, over 100. Over 100.
Yeah. Sorry, in English, 40 to 50 nanograms per mil, but well over 100 nanomoles per liter.
Yes, absolutely. Yeah.
They should have the D3. They should have the low dose naltrexone because it's no side effects. And the IMM 101, the heat killed mycobacterium,
or something along those lines,
which stimulates the immune system. Yeah, and all of those are completely safe to do.
Yes, indeed. And as I said, I in hindsight, I believe these things should be started on everybody with cancer, whatever cancer they have got, in order to make the other treatments work better and have less side effects, because certainly with the chemo you can reduce the dose, and that is a holy grail, to have non-toxic chemotherapy. You speak to anybody who's been through grueling chemotherapy, and I get to meet people who've just said, I had 3 courses, I'm not having any more. Even if you tell me I'm not having any more, I want to know what the alternatives are.
I've had patients that have said they've chosen death rather than go through another cycle of chemo.
Yes, yeah.
It is horrible. And if you half the dose of chemotherapeutic agents, would you roughly half the side effects as well? Is that about how it works?
All the side effects are in the top half.
Oh, I see.
This is my bit. When you get down to 50% of a lot of these agents, the side effect profile is really mild compared to the top half. And this is even accepted. They will give you 100%, and if you get bad side effects, they will reduce it by 10%. But the side effects, like a neuropathy, for instance, is already set in motion. It's not going to achieve that much. So to be able to set the doses at a lower level and not kick in some of these long-term side effects would be just incredibly useful. If I had the cancer, would I take it? Yeah, I would go straight on the low-dose naltrexone before I knew all the investigations had staged. That's how important I think it is.
So these 3, what we might call prerequisites or universal adjuncts, the vitamin D, the mycobacterium challenge, mycobacterium vaccae, the IMM 101, and the naltrexone. Is there any cancer therapies with which you could get interactive adverse reactions from giving those 3 preeminent interventions?
No, they only enhance. We have done so much work and published an IMN, and a lot of other people have too, with different cancer types. Vaccae was used with lung cancer, mesothelioma, and my colleagues and I did it with melanoma and colorectal cancer and pancreas. And so it's the same across the board. They seem to get a better outcome whether they're using chemotherapy or the immunotherapy. I don't see any negative association. The only negative association with when on low dose naltrexone, beware the opiates because of this clash over the opiate receptor.
Yeah.
That
Well,
and
all
that's-
it means is you'd have to give a higher dose of opiates for the same analgesic effect, doesn't it?
Well, yes, or I mean, this is the only thing that we're just very careful about.
Yeah,
But
right.
I've had patients on low dose naltrexone who then had trauma, and they've forgotten what I told them about opiates, and they go in and get a big slug of morphine or something, and they continue on that, and they've had no side effects. So what I'm doing is super caution from speculation.
Yeah,
Actually, in practice, there was none. And when I thought about this, is when I don't believe the low dose naltrexone is blocking the opiate receptors. It's just changing expression. It's blocking the inflammatory pathways. At the high dose, you put in, a very high dose of morphine, it floods the opiate receptors. The low dose naltrexone is not going to compete with it. So I'm just giving an example. You can speculate and be careful that, but actually, so many people have told me, they've had morphine and they never had any adverse reaction to it.
No, it's an abundance of caution. So vitamin D, D3, dirt cheap. Naltrexone, they can make it by the ton because it's off license. I mean, you can make it for essentially nothing. The IMM 101. How often would you have to give that? It's an intradermal injection, isn't it?
Yeah. Well, it is an intradermal injection, and as I mentioned, I was very saddened to hear the company literally run out of money. It's very unusual for a company to run out of money while doing trials. They usually run out of money because the big trials failed. And when I've gone through every trial they've been involved with, everyone's been positive. No side effects whatsoever. And I trace it all back basically to the lockdown, because the money was on the table then. And then it was going to be released. The second lockdown did it. The people kind of walked away, lost interest. And, I think people probably do realise how much damage the lockdown has done to everybody and everything, and the economy and everything. And I think the people who pushed it through and didn't listen to what many of us said, it will be an absolute disaster. You don't need to do it for an airborne disease. It's completely utter mad. I think they need to be held to account, because all the answers I've heard at the inquiries and this, that, they were nonsense. Absolute nonsense. Anyway.
Yeah, we could talk about whitewashing walls as well at the moment. We'll just both get really cross about it. But it just seems outrageous that these three things are done. So the IMM 101, the injection would be given how often?
Oh, sorry. When we gave it, we would give it once, and then a month later.
Oh, right.
And then 3 months later,
right.
And then 6 months, and then annual, say a 5-year program. Because once it's boosted, once it gets to a certain level, it stays up.
So you're talking about a visit to a practice nurse 4 times in the first year. It's nothing, is it?
It'll be nothing. And of course, I've done it on myself.
I wish I had it. Yeah, I'd love to have it.
When we were doing the trials and the COVID lockdown came along, I had to gather up everybody. They stopped all the trials. It was absolutely madness. But we had stuff that was meant to be for crushing. So I knew that it boosted the T-cell response. So I gave it to myself and measured. It was fascinating that if I'd had cancer or it very immunosuppressed, I would then needed to have given it, a month and then another 3 months. It lasted over 2 years with me.
Did you have any colds or COVID in that time?
Nothing, absolutely nothing. Well, I had COVID. I mounted an incredible response to COVID because we were able to test the T-cell. I told everybody at the time, forget antibodies. Forget vaccines in making antibodies. It's the T-cell response that guards against these things.
Yeah, cellular immunity. Absolutely.
Cellular immunity. So anyway, we were doing a lot of T-cell responses for cancer, everything. And one of the guys got interested in doing COVID, and he wanted me, because I was unvaccinated, for my response. And he came back and he told me, he said, "You've got the highest T-cell response against the SARS virus we've ever seen. Have you had it?" And I said, "No, I've never been ill with it, and I've never had the vaccine." And it was twice as high as all these people in their 30s who had had 2 shots of ordinary vaccine. So that is why, I'm a living example that you need high T-cell responses. And I've never had, at that time, going through the cold or flu either at all, until recently. I had a bad few weeks of it. I think it was probably RSV virus going around.
Okay. Oh, really?
So many
You had that?
people I know had it. I mean, it wasn't. You didn't have to stay in bed or anything. It was just very irritating symptoms.
Right.
But but overall, you're talking about percentages of catching things, and when you do, how ill you are with it. And there's no doubt that all the people who were on this for the early melanoma trials, they picked up, they never get colds or flu. And that was the big signal to me that it was the T cell innate thing that was controlling the cancer, not any antibody or anything like that.
And preventing the infection. So obviously you'd had COVID without realizing you had it, and because you were protected by the IMM 101, basically you didn't even know you had it, but you still mounted this fantastic cellular immune response. And you probably still got.
I almost certainly do have it. It's a T cell that be there long term.
Yeah.
It would have activated the memory T cell, so they're programmed. So if I get exposed to it again, up there.
Well, of course, it'd be a different variant now, so you could be reinfected with a different variant, but.
But the T cells go for the more conserved areas that the antibody. This idea of
isn't that clever? The T cells actually go for the more conserved areas of the virus. That is amazing.
Mm-hmm. And that was the basis of how Børge Sørensen, who I did the HIV vaccine with in Norway, that was the way he picked what should be in the vaccine, not the whole envelope that the Americans did time after time after time, but he just picked the epitopes that the T cells would go for, and which, if they changed, the virus wouldn't survive. I mean, a really sensible, logical way. And again, this has been turned down by all the big authorities again and again and again. It just seems rather like, to me, that the big pharma's running this. It doesn't want anyone to be killed.
Absolutely. I mean,
chronic users of its products.
Absolutely, yeah. But I'm just, my mind's blown by that. So we've got the T cells that we all have. And when a virus comes along, it says, oh, well, that bit on the edge of the virus there, that'll probably mutate next week. I'll ignore that bit. But this bit in the core of the virus, that's going to stay the same. So what I'll do is I'll make an immune response against the core part, because there's no point doing that bit. That's going to change next week. It's really clever that it can do that.
Yeah.
And really brilliant pharmacologists can duplicate that, saying, OK, ignore the bits that are going to change. Let's go for the core antigens that are going to stay the same regardless of how much the virus mutates, because it's still in this case it's still a SARS coronavirus too. It doesn't become doesn't become a smallpox virus or something. It's still it's still basically the same, and we can duplicate that. But that's so amazing that the body can do that in the first place. Amazing that we can duplicate that, and not surprising at all that Big Pharma turns that down.
Well, I mean, the obvious conclusion I immediately jumped to is that there's no need for flu vaccines if you gave this, and you wouldn't have to mess around every year trying to inaccurately predict the next variant.
Let's drift off into a parallel universe. Let's just imagine that instead of the vaccine of the COVID vaccine rollout, we rolled out the IMM 101 vacci, mycobacterium vacci vaccine, and we gave that to everyone. Then it's quite possible, without venturing into the realms of complete fantasy, that would have prevented the majority of viral infections, including COVID and influenza, over the next year or two. And it's also quite conceivable that would have massively reduced the amount of new cancer diagnoses over the next decade or two. I mean, am I getting carried away?
Yeah. Well, I'm actually, you're hitting a raw nerve here, because I actually said at the outbreak of the COVID, when they were, but this is like pre-lockdown, we had a lot of people in the hospital getting ill. I actually offered this to Whitty. I'd established that there was enough stored in the batch that we could have offered it to everybody in the front line in the NHS, and say in the south of London, and we wouldn't have had enough for the north of London, but you could have used that as a control. And guess what? And all the papers, everything available. you know what his response was?
Our chief medical officer, who's a supposedly a highly educated physician, I imagine he welcomed it with open arms, did he, Gus?
Yes, well, unfortunately, people are overeducated above their intelligence these days. So he said it needs more work in animals. I said it's been in thousands of people in the big TB trials. It's been in hundreds of people for this, and it works the T cell. And they were just fixated on this vaccine program. And I mean, the fact everybody rolled out did the same. It was like a mass psyop that was going on.
Yeah.
And this is why, I'll mention it again. I ended up editing the book "Death of Science" because that's exactly what was going on. People were not looking at the evidence, and it was worse than that. They suppressed all debate.
Yeah.
So people who wanted to...
We'll put the link. It's excellent.
Parts of it.
Nearly all. Yeah, nearly all.
and so this to me is the most Orwellian, draconian thing that happened, that even my own colleagues wouldn't debate.
I never thought in our lifetimes that we'd have to start... I thought we could spend our lives working out how to look after patients. I never thought we'd have to fight these political battles. And personally, I'm personally offended by it because I have to spend time thinking about pussyfooting around what I can say and what I can't say, when I should be spending my entire time working out how to prevent human pain, suffering and death. And the role of the politicians and the administrators should be saying, well, Professor Dalgleish, how can we help you do this?
Well, I agree entirely. That's exactly what they should do. Yeah. And I mean, the fact they cannot be totally unaware because of so many patients have benefited from these immunological programs. I mean, I was doing 25 years ago, and now it's become de rigueur, and it's the same thing with things like low dose naltrexone. I'm sure that in 10 years' time it will become de rigueur eventually because there will be a force. But I want it now because there's no need. There's no need for any other work.
We have relatives dying of cancer with cancer now. We have friends with chronic inflammatory conditions now. I just couldn't agree more.
And the other thing is, which is annoying, that I know Whitty and people like that have dismissed me as a cancer doc, and I don't know anything about infection and immunity and what have you, which is a bit rich, knowing that my impact on HIV is greater than probably anybody else at the moment.
The CD4 receptor, I think you're a record
and the pathogenesis. We worked out the pathogenesis of it.
I think your HIV record is more impressive than people, I don't know, maybe people like Tony Fauci,
Well, the thing about my record in HIV and Tony Fauci's is that I wrote and did it all myself, where Tony puts his name on anybody else's work he thinks is good. He cannot possibly have written all those papers. You know how it works. And that's the culture. They put the name on if it's going to be good. Anyhow, we're not going to go there. But the other thing that I think is really important that people dismiss is the thalidomide story.
Yes.
I saw clinically patients who were steroid-resistant, horrible disease. Yeah. And I spoke to a chap called Mike Denman, who was in Northwick Park when I was there at the time. Yep. And I said, with these things, would it not be worth trying thalidomide on these people? And he agreed, and then he was able to tell me the story of a friend of his in Israel who had used thalidomide for somebody with bad leprosy to help him sleep, and it improved the leprosy. And this is what we call, it inhibits this Th2 inflammatory response. So I used it on a couple of, very rare, these patients, but they had fantastic responses. I mean, miracles.
Which patients?
They were patients with steroid-resistant autoimmunity,
right.
Really badly, involving multiple ulcerations from the mouth to the anus, with terrible skin diseases, what have you, and even high-dose steroids. And then they'd be losing weight because they couldn't eat or drink, and they had to be on drips and what have you. And when we gave the first thalidomide, they couldn't even swallow, so I had to squirt it down their But they improved. The next day they were improving, and they were completely better 2 days later. And we saw that with several of these serious autoimmune diseases, some horrible skin and joint problems.
The thalidomide was available at the time, was it? You could get thalidomide from the pharmacy.
We could only get it on a special permission, which fortunately Mike Denman had that permission to do it, so he allowed me to do it. And it was then that I realised that it was going to be exceptionally good for HIV patients with anorexia. And then the next leap was cachexia cancer patients. So that's what we wanted to use it for. But, once again, the establishment is full of people who cannot see beyond their own feet. And they all said, no, this drug causes birth defects. We can't possibly allow you to do this. And I said, but all the patients when we want to give it to are not going to be women of pregnant age. And in cancer, if they are, we give chemotherapy. That's far more tetragenic than thalidomide. We just make sure they're not pregnant. It's not. At any rate, they turned that down. I wrote a terrible review article of how it could be so beneficial in all these things. And this is the one case of good big pharma, because they weren't. They were a very small company, and that was Celgene, and they actually funded my lab and a clinical trial which was positive, and we took on from there, and I realised that this drug could be improved. It took a long fight, but we got variants made, lenalidomide, pomalidomide. They are the drugs for myeloma, multiple myeloma, widely used in lymphoma, etc. So, that track record is really, really important for low dose naltrexone, because I see low dose naltrexone as a very similar, more broadly applicable thing to the thalidomide analogues. Where not
only that, it's your personal track record. You've taken a drug like thalidomide. You've constructed a form called lenalidomide. You've started using it in myeloma and lymphoma, and now that's pretty well standard treatment across the world, is it?
I was told that it still sells about $10 billion worldwide. So, I mean,
are you in for a cut?
I've done very, very, very well out of that.
So you discovered it and you get diddly squat.
Actually, yes, that's true, but I did get my lab funded by them at a very, very good rate.
I should hope so. Out of 10 billion, I think they can afford that.
No, this was long before they started making that money. They funded me well.
Oh, okay, right. Well, a good investment then.
Yeah, it was because the guy at the top, he just intuitively trusted me, whereas many of the people who sit on these committees said no, he's got no track record, etc. And he trusted me, and he got massively rewarded. I got rewarded because I was able to have my university labs funded outside, which is really important these days.
Yeah, your boss would be pleased with you.
And after the MRC and the CRUK and the Wellcome Trust had all turned me down for doing the same project, so I was delighted. So I'm not. I'm just really, really delighted, and I've got friends, very good friends of mine, who today are stable because of they're on lenalidomide every day.
Yeah. But isn't it incredible? You there have developed, basically you've discovered a completely new application that's benefited millions of people really around the world, has made billions of dollars. Most people would have made sure that their invention benefited them, and you could have been like in the Bill Gates category. But you have lived this life which is just to ease human pain, suffering, and death. And the fact that someone else has made $10 billion out of it is just a bit of a side effect, really.
Well, it shows. I mean, they listened to me when nobody else would listen. Yeah. They reaped the rewards. They were a small biotech with only 12 employees when they came to this decision that they'd fund me to do work on thalidomide. So that was. So, but and at one stage they were bigger than GSK.
Wow.
You know how they do these things on the stock.
Yeah, just because they listen to you and the other experts, it's just incredible. Are 4.5 milligram tablets of naltrexone available? Because I looked in BNF this morning, I could only see 25 and 50s.
Right, this is a very interesting area. They're 25, 50s, etc., and you take about 200 milligrams if you're going to use them in the
Opiates, yeah.
thing. So these very small doses are not available without what they call compounding. So you have to take the 50 milligram, grind it up, weigh it out, repackage it. That's an expensive business to do. So
that's why we have pharmacists, isn't it? They should. Any pharmacist should be able to do that.
Well, they do, but it'll cost you because it's not on the NHS.
Right, okay.
So Dixon's pharmacist in Glasgow started to get this demand for multiple sclerosis patients. And indeed, there are really good papers showing benefits of multiple sclerosis. So once again, why is it not used? But the demand is in the thousands. Glasgow being the highest area of multiple sclerosis in the country. So there's big demand. They're also probably the area with the lowest vitamin D in the country as well.
That was just came to my mind. It's a built-up city. It's far north. It's people are indoors a lot of the time because it's cold.
Very bad lifestyle choices. So MS is a big issue. It clearly works. I've spoken to the GPs up there, neurologists. They love using the low dose naltrexone, and they've actually managed with cases, but you have to prove the case that low dose naltrexone has revolutionised their multiple sclerosis. Then they go for the NHS to approve it and pay for it for those patients. And it makes perfect sense because it's dirt cheap compared to the things that are approved, which are in the thousands, whereas this is in the...
But it's got to be 4.5 milligrams. In your paper it said if you give 6 milligrams, the effect reduces. I mean, do you work it out in terms of milligrams per kilogram, or is just 4.5 milligrams seems to be the magic dose?
Smaller people feel better on 3 milligrams. So they now make the doses in 1.5, 3, and 4.5, and the chemists usually want me to start all the patients on just a 1 milligram first, which they do in a dropper form, just to make sure there's no unexpected interactions with other things.
I mean, if we had that as a liquid, it'd be really easy to do. So for example, I've given huge amounts of intravenous morphine, and it comes in 1 mil, 10 milligrams in a mil. And because that's a bit hard to titrate, what we do is we pull the 1 mil of morphine into your syringe, then you add your 10 mils of water or saline, and because you're adding that you get perfect distribution. Then when you've given 1 mil, you've given 0. You're given it's 1 mil equals 1 milligram. So that would be really easy to do if we had it in a liquid preparation for naltrexone.
Yeah, very, 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 very easy. And to give you an idea of how many people are absolutely convinced it helps them, I mean, I've spoken to multiple sclerosis patients who said that they were wheelchair bound before they started low dose naltrexone, and now when I see or talk to them, you never think they're ever ill. They're really that incapacitated. And that pharmacy, Dixon's, does over 30,000 scripts, just one pharmacy. So it shows that a lot of people have woken up to the benefit. Now, you showed that paper, LDN and cancer.
Yep.
When I started writing these scripts out for cancer patients, I was told I was the only one who was writing low dose naltrexone script for cancer patients. And after that paper was published, he now tells me that there's many doctors writing it out. So they know, and they know there's a benefit. So there should be a forum for approving this.
And there should be a way of collecting this data prospectively. It's basically a stage 4 clinical trial, isn't it?
It is, and
why don't we? Which is better than a stage 3 clinical trial.
It is much better, and this is why it's interesting mentioning lenalidomide. Lenalidomide had stage 4 approval in France before it was ever approved here, using the stage 4 process, because it was seen to be such an unmet need, and of course that stage 4 process proved it.
But the regulatory agencies don't take that kind of data. They look for the stage 3 data.
Yeah,
the $20 million RCT industry funded data.
Yeah, well, we now know the only reason for doing that is to keep anything useful out of the patient's hands. I mean, I hate to be so cynical, but my experience leads me to
it's completely realistic.
Yeah. And so the other thing is that, you know, a stage 4 study is much better than a big randomized study for these agents which are already freely available for everybody.
Yes.
Why do you need to do that? Now, I've looked at something else which I'm not going to mention on this. I'm not going to complicate any further. But something I thought might help for the joints. It was recommended by a patient, so I tried it. And so I tried it, it improved. I stopped, the problem came back. I took it again, disappeared. I did this randomized, non-controlled trial on myself and came to the only conclusion was, this was really superb for me. I didn't need to wait for a randomized controlled trial of this thing, which is never going to be done, by the way.
Because all the basic toxicology, the stage 1 and stage 2 stuff's already been done.
Yes, all that's been done. Yeah. And actually, we've also done that. Why is it 4.5 milligram and below, and not 4.5 milligram and above? Because they're two different drugs. The way they're absorbed, you know, all drugs come in two forms.
It's the same molecule.
It's the same molecule, but in a different form. And the first form is absorbed up to 4.5. After that, it's drowned out by the other molecule. You have left molecules and right molecules. This became very, very important with thalidomide.
Because I see. It's the chirality.
Chirality. They found that one of them was the cause of the birth defects.
Yes.
So they very cleverly spent, and I spoke to the guy who actually did all this work. So I know, and they then converted it and made it just in the right form.
Yeah, all L form or D form, whatever.
Yeah, exactly. But as soon as they gave it to various animals and things, but as soon as they gave it to humans, the human liver immediately converts it back to the left.
So the left was the teratogenic form, was it?
Yeah, I can't be 100% sure.
Yeah, yeah.
I don't want to go down as
no, sorry, it's a Tuesday.
I would have to check the thing because I have done chirality.
But anyway, you can give the right thalidomide, and the human liver will convert it into the teratogenic form of the thalidomide.
Exactly, and that's what this guy sat down and told me. He said this is why, and I used his evidence to put pressure on them to make the analogues, because I said it's pointless going down the chiral path. This guy's already done it. It's a waste
Just out of interest, the lenalidomide, is that teratogenic?
No, it's not, but it has to be treated as such because of its close relationship with thalidomide.
Yeah.
In fact, it has very few side effects compared with thalidomide. When I was doing a lot of work with thalidomide, I was the one I told them, told Celgene, I said that we have a big issue, a big problem, and this is how I got the analogues done. I said I'm not worried about heterogeneity, but it's very clear for conditions, chronic conditions, cancer, you need to give this drug for a long time, daily. But everybody starts getting neuropathy, whether it be 6-8 weeks. It's absolutely, you cannot continue with it. So you must.
This is with the lenalidomide.
Yeah. So that's what sparked them to finally make all these drugs. And again, we just screened them all, and lenalidomide just ticked all the boxes.
Oh, so you don't get the neuropathy with the lenalidomide?
No. And then when it went into the clinic, this is the first thing I was looking for.
You don't get it.
You don't get it, and actually, people who had neuropathy from thalidomide said it actually improved when they went to lenalidomide.
So the thalidomide causes neuropathy. The lenalidomide does not cause neuropathy.
No, it does not. No.
But it does treat myeloma and lymphoma.
Yeah, it's even better than thalidomide in inhibiting all the main pathways. And this is another really important thing. Lenalidomide, pomalidomide, they inhibit so many pathways. They inhibit inflammatory, angiogenesis, there's a whole range. And so much so that Celgene told me to stop looking because they only wanted one good explanation.
Yeah, but it fulfills Bradford Hill really nicely, doesn't it?
Yeah, but what is interesting from that book, that paper that you showed that we did, low dose naltrexone is exactly the same. The
Yes.
more we look, the more pathways it interferes with.
Well, I've got four: arresting tumor growth, increasing apoptosis, increasing immunity, and reducing inflammation.
I mean, it's,
And another one, it seems to be that it promotes gene expression of apoptotic
yes, this is the brilliant.
proteins.
That's right. This is the brilliant work that Wei Lu did.
Amazing.
He did all this off his own bat.
He sounds like a really useful guy, this.
Oh, he's fantastic. He came to me having had a big history and past in looking at scientific aspects of the cannabinoids.
Yes,
So-
I've read some of those papers.
Yeah, it's really, really good. And he was able to show that in some cases there's synergy between LDN and the cannabinoids. And more importantly, due to what I thought there had been a big error in the lab, he showed that the cannabinoids have significant anti-cancer activity only if they're used intermittently. So
Isn't that interesting?
If you take them daily, nothing happens.
Is that true? Is that true for the LDN as well, for low dose naltrexone?
Well, people have posited this, that this might be better 3 days on or 3 days off.
Really?
My argument is I've always used it daily at the low doses, and at the low doses, it's only in the blood for a few hours, so it is intermittent. It is past already.
yeah.
That's my argument. That but with the CBD stuff, and we did it in a range of cell lines, it's very clear. In fact, I thought they'd got everything mixed up when they gave me all the results, because the cell lines that were dying faster and quicker were the ones that had CBD for 3 days and then withdrawn. That was just meant to be using as a control for the effect of washing out the nutrients, the food for the cells. They do it. It's a regular thing to do. And I said, this is unbelievable.
So, sorry, say that last bit again, Gus. I didn't. Why is it?
When you're looking at cell death, say over a month, you have to sort of keep the food and liquid and nutrients up. So you sort of wash the cells out and put them in fresh nutrients all the time.
Yes.
And so when you're looking at the long-term effect, you give them their food and water basically, and you continue the CBD. But just to see whether that process has any effect on it, you wash it out and see, or to see whether the benefits short-term or long-term. But it was so clear, 3 days followed by washout, then no more, the cells go into apoptosis like you wouldn't believe. If you keep the same dose of CBD up, the cells just go a bit slow. They don't die.
Have you got?
They slow down.
It's a bit geeky, but is there a mechanism for that?
Well, my only explanation, and if other people have got one, I'd love to hear it and be explained. But my only gut feeling explanation is we're watching cold turkey here. The tumour cell lines have got rapidly addicted to the cannabinoid pathways. And in cells, the opiate and the cannabinoid pathways, they're really big, important pathway cells. So they've got very highly addicted to it, and then you stop it, and then they go into apoptosis. I mean,
amazing. So there's something about the intracellular biochemistry which becomes tolerant to the presence of a particular molecule.
Yeah. So once again, it opens up, and that's another reason. Like there's several other drugs which might be better off in low doses and intermittency. I think it's a whole new potential of the pharmacology. As I said,
it really is a whole new way of thinking. That to me,
it is. Yeah. And to me, it's just incredible, having been brought up, the more is the better, because that is oncology. In fact, we don't, when you develop a drug, basically, chemotherapy drugs, there's a thing called LD50. I mean, they keep up
lethal dose,
50% of the mice are dead, and then they start around that and reduce it which is why so many of them are so toxic, is because they're developed like that. And I would say that there's no need for it.
No, I agree completely. But we have the same with aspirin as well. Post-MI, for example, post-heart attack, 300 milligrams of sublingual aspirin is more effective than 600 milligrams of sublingual aspirin. So
absolutely,
there's that sweet spot, this window, this therapeutic range.
And just let me remind myself, I suppose,
please.
I think in the Graham Rook, who developed Mycobacterium vaccae for TB to boost the immune system for TB protection, all the studies were being done in Africa. In order to boost its efficacy, you could see there was some. They increased the dose, no difference, but he did what enters into this territory. He started reducing the dose. And a tenth of the dose, the response was far, far better. So it's another low dose. So the vaccae and obiense are a fraction of the dose in which they were initially developed.
Really?
So once again, it is, and so these things are what I call bell-shaped curve.
Yeah.
So you get to the top, and that's low dose naltrexone is at the top. Give more, you lose the benefit, just like that. So it's a biological, actually. If you got to classify it, it's a biological because it's not the more the merrier.
I mean, many people watching will realise what a massive pandemic tuberculosis is. I mean, it's huge in Africa and India and Asia, and causes indescribable suffering. I mean, I saw a child with tuberculosis meningitis in India, and you could just see this child was suffering this most intolerable pain and agitation from the meninges. And even if being treated, it would take, with traditional treatments, it would take weeks for the inflammation to go down. If we could protect people from against this, that is, it's hard to describe how massive an opportunity this is. Well, it's simply being ignored by international agencies, as far as I can see.
Yes, and we'd like to know why, when they suck so much money out of our governments for vaccinating the world, Gavi, CEPI, United Nations, they're all got Bill Gates behind it, and Fauci working away there, when there is something really simple. And I know they've all seen this data, because emissaries have given it to these people, and they just basically show no interest at all. The M. vaccae, what needs to be appreciated about it, that they did a study, and I think it was led by people from University College. They did it in Africa in HIV, the height of it. They gave the vaccae to people HIV positive, there was no treatment, in tuberculosis areas where there was a high risk of tuberculosis.
And of course, the HIV and the TB together are real bad double whammy,
real
aren't they?
unbelievable. But they had a highly significant reduction in TB infection in those given the vaccae compared to the control. Now, that alone should be enough for these agencies to take it up and run with it.
Yeah.
I mean, it's unbelievable.
Yeah.
Oh no, they ignore it. It's honestly like they don't want anything simple, especially something simple, cheap, and non-toxic.
We were just chatting about this before we came on air, weren't we? The idea that there's so many basic, simple things that could be done. So making everyone vitamin D replete. Optimizing. One example we were talking about was iodine. In Japan and Korea, the seaweed, which is high in iodine, they have low rates of breast cancer, and there's mechanisms that whereby this would make sense. We don't eat seaweed in England and the United States. We have very low amounts of iodine, but we have very high amounts of breast cancer and other glandular cancers. I think it has to be said.
Yes,
pancreatic cancer, prostate cancer.
Yeah, adenocarcinomas of any origin.
Do you think iodine is a factor in all of those?
I do. It's one of the others on my list of looking at great detail, and I have been looking at it, and I think that the evidence for supplementing it used to call Lugol's iodine, wasn't it?
I take Lugol's 15%.
Right, and the evidence for that actually is enormous, and would be the next one I would add to this list of prevent you deteriorating, getting cancer. So I'd make it the fourth thing after vitamin D, the iodine, LDN, and then the iodine.
Because if you think about it, hunter-gatherers, the reason that we spread around the world was on the seashore. And what do you eat? You eat limpets, you eat shellfish, you eat seaweed, and fish if you can catch it. That's the way we kind of. One of the main ways we spread around the world. I'll just tell you an interesting story. I'm quite naughty, really, and I've been going into chemists lately asking for iodine, and because you can't buy Lugos iodine in British chemists. And this is completely true. I went into a well-known high street chain of chemists, and I said to the assistant, "Can I have some iodine, please?" She said, "Oh, I don't know about that." She went to get the pharmacist. I said, "Can I have some Lugos iodine?" And this is a completely qualified pharmacist. She said to me, "What's that?" I couldn't believe it. And I went into another well-known high street pharmacy recently, and I said, "Can I have some iodine, please?" She said, "Oh, we haven't got any. I'll get the pharmacist." I said to the pharmacist, "You don't have iodine, do you?" He said, "No." I said, "Why not?" And the pharmacist said, "Oh, I don't know. Maybe people have been abusing it." You can imagine all these people having iodine parties getting stoked up on iodine. It's just preposterous. Basically they didn't have a clue, and these are the pharmacists that are supposed to be guiding the drug use of the entire country. And the old saying was, "If you know not the where, when and why, give you then the K and I." It's what we used up until about 1910 or whatever. That was all doctors would do that, and now the pharmacists haven't even heard of it. Sorry, it's difficult not to get emotional about these things. It's so absurd.
You're talking to the right person. I've been through all this so often.
So absurd. Yeah. And
I'm not going to mention it because it deflects from this, but there was something else that I wanted for a patient that it occurred to me would be very, very useful, this drug. And I went to this is what reminded me. I went to the chemist and I said, I'd like an oral version of this drug. I've heard that it does exist. And the chemist said, "Oh yes, it does. It's very, very good. But we're not allowed to prescribe it." As a chemist, and then he told me to go to a certain health food shop and to ask specifically for the head person and to ask for the drug. And he wanted it orally, and that I had been sent by the chemist. I mean,
oi! I know a mate in the pub down the road. Just ask him. He's got some under the counter, mate. Slip him 20 quid and he'll give you one. It's like underground porn or something, isn't it? It's and this really serious point that comes from this, Gus, is we've talked about D3. Okay, easy enough to give yourself D3. Naltrexone a little more difficult to get. Iodine certainly possible to get. The IMM 101 unfortunately not possible to get. But the problem is, because these treatments, the evidence that these treatments and other things that we could talk about, other repurposed drugs that we could talk about, mebendazole, fenbendazole, ivermectin, is it methylene blue? I'm not sure. I'm not advising people take any of those, of course. We don't give medical advice. But the point is, because so many of these treatments, there's so many repurposed treatments and new treatments that are turkey tail mushroom.
Yes.
There's so many that have got so many anecdotal reports. If you ask 100 people, there's probably one that knows someone who believes that their cancer has been taken away, gone into remission with these things. That people are taking medicine into their own hands. And they shouldn't have to do that. The precise dose of the precise preparation should be given to them by their doctor, but by the same route. And it's actually quite dangerous, I think, that people are taking medicine into their own hands now out of sheer frustration.
Yes, it is sheer frustration.
With orthodoxy and desperation. I get emails every day from desperate people. And they're begging me for medical advice, and of course I can't give it because I don't know them. And it just seems a tragic situation that these simple things are there, they're available, they're known, and people are taking medicine into their own hands out of sheer frustration. And it also seems to me that doctors like yourself with 50 years experience, probably, you're a professor of medicine. The idea that you can't prescribe what you want, when the heck you want to, who the heck you want to prescribe it to, just seems outrageous. Because who knows better than someone with a lifetime experience in academic medicine? It's just.
Well, I must say I find this really, really frustrating that we've got to this situation. There's just so much unnecessary overall management that stops me from doing things that I want to do that I know well. I mean, a very good example is that, and I realised the checkpoint inhibitors were very useful in certain things. I had an understanding of the immune response and what patients might be useful. I was allowed to prescribe it for stage 4 melanoma when it was approved. And I found that there were some other cancers that had similar characteristics that I think would benefit from this. Oh, not allowed. It's not being approved for that trial. And then I could say, I had to remind them, I said, I have my right to do it off license. Yeah. And you've got to allow me to do it. And they gave me all the warnings and stuff. You can be reported to the GMC. I mean, what is this is why.
You're actually threatened.
You're threatened.
Yeah.
But yeah. I said, no, I really want to do this and I take full responsibility, etc. And that's when we first started to see that other cancers started responding to these things. And one of them was lung cancer, because we knew from MVACI work that melanoma and lung cancer had some similarities. It was the immune response. And so now these patients, they said, I'm not allowed to do, even if it's off license, but it's in the hospital, they're not going to allow me this, that and the other. Now, several years later, these drugs are all approved for the very things that I was wanting to do. So anybody who tries to lead the way is basically just like a Monty Python foot stamped on.
Yep. People of a certain age will remember the Monty Python foot. And it's a side point, but while I'm having a bit of a rant, working in organisations these days is intolerable anyway. You have to subscribe to so many political doctrines. It's just, and you have to attend so many courses which are basically political in nature.
I'm afraid that's absolutely the national
it's
health
intolerable.
Service is being destroyed by this dogma.
Yeah, and the higher education. We won't go into it, but because we want this video to go on air. But it's a culture where people are conformity is demanded, and there's been previous cultures where conformity is demanded. You will make this particular salute. You will click your heels.
Or
you will say Yavul. We've been here before, and people just don't seem to see the dangers.
The similarities. I can see George Orwell behind you.
Oh, yeah.
What vision he had.
Yeah.
Because we are now in a dystopian world, whether you like it or not. The infiltration's been at the very, very top. It's now looking at what went on with COVID. This came from the very, very top. United Nations, WHO, all these things, Gavi, CEPI, they were all set up to basically push for a pandemic, which I believe if they hadn't have done all these things, we would never have suffered. This is the madness of the whole thing.
Yeah, in fact, even there might be a layer above the layer that we know about. This top-down control. Everyone knows now what they're not allowed. No one's written me a list of things saying, John, you can't talk about this, you can't talk about that, you can't talk about the other. You just know. There's a whole list of things you can't talk about, largely because people have been in prison for it and persecuted for it in various ways. And I really, really resent the self-censorship I have to work under. It's anyway, it's a separate rant.
But it's true, and it's my thing is, you're not allowed to do that. I'd like to use this drug and that drug. There's no evidence. I mean, it's totally negative. And I will say that when I first went out, before we really had much useful treatment, I said, why don't we do this, that, and the other? And they'll go, well, that's a good idea. Like, try it, but make sure the patient knows it's not normal, and that they're fully informed, and we do it, and then things would work. And I was reminded that the great chemotherapy we had for Hodgkin's disease, that didn't ever come through big randomised controlled trials. No, it went with what I've been campaigning for to go back to, is adaptive trials. So the guy, I think Mike Peckham, who was the head of radiotherapy, interestingly, who actually ended up doing these chemotherapy studies, you start with one drug, well, that worked quite well, but not well enough. Let's add another one in. Let's add another one in. Oh, there's some side effects. So we had to add a drug in for the side effects. I think it's dexamethasone. Oh, that works far better than anything else. Leave it up
It's just evolution, isn't it?
It's evolution. And that's
it's a biological evolution.
That's how we should be practicing medicine. Yeah. And you don't need big randomised trials, I believe.
Incremental improvements.
Incremental improvements, and then you do your randomised study, as it were, as I mentioned with myself with this agent. Yep. You see if it works for the patient, and if you withdraw it, do they relapse, put it back in, do they better? I mean, what bit do these guys not understand? Yeah. Well, I'll tell you what they do understand is that unless it's all been done in this way, then it's not going to be approved, not allowed. Why is that? It's because Big Pharma have hijacked the regulatory authorities, and they've hijacked education. The doctor's education is all hijacked by a Big Pharma now. Yep. I think the medical schools are a disgrace. They're not educating people. They are training technicians in particular jobs. Yep. You don't get this broad expertise as to how to treat and look after patients better.
It's called assess, plan, implement, evaluate. And then that evaluation feeds through into your next cycle of assess, plan, implement, and evaluate. It's so simple. I actually went to see well, I'll be careful what I say, but I went to see a very senior doctor for a particular issue. Well, it's for a prostate issue. And I said, I've been taking zinc and vitamin D. I think that probably helps. And this very senior doctor said to me, oh, I don't know about that. He just follows the nice guidelines. You know, the idea that you wouldn't want to make your vitamin D and zinc replete in anything to do with the prostate, and yet not on the guidelines, not interested in it. It's called curiosity deficit disorder.
Yes, that's a good. I've not heard of that before.
It's a virus, yeah. So it blocks the curiosity receptors in the brain. And it's spread around the entire world. So everyone's curiosity ligands can't get into the postsynaptic neuron.
Yeah.
So everyone's going around with this zombie-like curiosity deficit disorder. Duh. I don't know, mate. I just follow the guidelines.
When I refer to the medical school and how they are just indoctrinated and inculcated, they're not being taught to think. One of my last lectures I gave, or I gave up exasperated talking to the medical students, was I was telling them about a particular mechanism, and which is what they want to know. And then I said it's very similar to this other mechanism in the other pathways and things like that. So one way of looking at things is to see similarities when only differences appear, and vice versa.
Which is a Bradford Hill criteria analogy.
Is a way to think. And this student in the front row, so one of the right in the way, everything, put up, please sir, we don't need to know this, it's not in our curriculum. And I thought, if that is what university has descended to, why bother? Why bother going to university? Why not just read the thing and do the multiple choice and not bother talking to people like me wanting to expand their minds and teach them how to think? They weren't interested.
And the arrogance of thinking that your lifetime in medicine is of no value to them is just insulting.
Yeah.
Yeah. So, I mean, I could keep you talking all day, but just, I mean, when you first went into clinical academic medicine, and you're a practicing physician, and you're able to instigate these things.
Yes.
I mean, what is the difference? How much more freedom did you have then than you have now?
Far, far more then. I really did. I mean, if you were even as a registrar, providing my consultant degree, I tried lots of what I would call bespoke treatments for people's conditions. and I was allowed to. There was no inhibition, unless the consultant might say, well, I think this guy's a bit out of order, tell the pharmacist only if I agree.
Yeah.
You know, I never had that, and that was wonderful. Then as a consultant, I was able to do exactly what I thought, and I was a general physician for 5 years, as well as being immunology doing cancer, so I saw everything. And I mean, talk about repurposing. Actually, one of my proudest achievements was repurposing a chemotherapy for a very, very serious arthritis. And the person had hypertrophic pulmonary osteoarthropathy, which is what it is, a horrible arthritis due to hormones produced by lung cancer.
Oh,
now,
okay.
At the time, the chemotherapy for lung cancer was not approved, as there was no evidence that it worked well. It was that long ago. Then slowly we started getting some evidence, but anyhow. So I said to the person, we know that this big tumour you've got, which had already had radiotherapy, and the cancer surgery was no longer an issue possible. So I said, the arthritis we actually know from papers is produced by a hormone being produced by the tumour. Why don't we give some chemotherapy to the tumour, not on the grounds we're going to cure the tumour, but if we can dumb it down so it stops producing that hormone, perhaps the arthritis will improve.
It's kind of a paraneoplastic effect, isn't it?
A paraneoplastic effect. Yeah. So I discussed it with the patient and said she couldn't even go to the toilet herself, so that's how bad the arthritis was. Horrible, horrible. Any rate, I discussed it with a consultant physician elsewhere, because I was basically operating as a consultant at the time, but not in that area. And he kind of said, well, go for it, see. The pharmacist approved it. We gave her the chemotherapy. And 3 days later, when I did the ward round, she jumped off the bed, came up and gave me a wonderful big cuddle.
Not surprised, yeah.
It worked. Even I was surprised at the extent of which it worked. Yeah. But so that type.
That's just because you're using your intuition, your tacit medical knowledge that you were allowed to do in those days.
Yes, but now you wouldn't be able to do that.
So you just leave your patient in bed suffering.
Yeah, exactly.
Well, yeah. Right, well, while we're still sane, Professor, thank you so much, as always.
Thank you.
Low dose naltrexone, LDN, it's going to become universal. It's just a case of how many people suffer till it becomes standard. And unless, of course, Big Pharma win and they get it banned like other drugs that could be mentioned. But, I guess the battle's on. But we've done our bit. We've spread the information that you've developed over decades, and we really appreciate it.
And if I could just point out, there are some books on LDN.
Must get that.
The LDN Trust. There's now 3 of them. I confess I have contributed to these.
Yep. Have we got links for those, Gus?
There's 3 of them. Yes, the LDN Trust website has it.
Oh, right, LDN Trust website, right.
Yeah. And I am staggered that the amount of research that's been done in other conditions, particularly neurological.
Interesting.
I mean, there's really fascinating benefits, and I've given it to a cancer patient who had Parkinson's, and the Parkinson's improved, and they've been on Parkinson's for ages, and they said, and it's actually in that there are people working on the mechanism. So, how, with all these other people so interested and excited by it, it's even more amazing that the vast majority of doctors say, low dose naltrexone, never heard of it.
Yeah. and of course, anything that we can use to reduce inflammation that's not a steroid is a good thing. I mean, the amount of people that quietly die from pneumonia on steroids, and it's never attributed. I'm sure it's in the thousands.
And of course, the non-steroidal anti-inflammatories, they're all besieged with gastric problems. Low dose naltrexone has none of that. Yeah. So it's really unique. That's because it targets this totally different pathway.
And targets many different pathways, including altering gene expression, which is just amazing. Amazing interaction between a simple molecule and this amazing system of emergent complexity that we are. Professor, thank you so much as always.
Thank you. Bye.
Bye.